Hi class, and welcome to chapter 17, which will be on the heart, a little bit of the anatomy of the heart, and then the electrical changes in the heart. This chapter is divided into two parts, and we'll get through two parts in this video today. So a little bit about the heart and a review from anatomy. Your heart is a transport system that consists of two side-by-side pumps. The right side of the heart receives oxygen-poor blood from all the tissues, and it will pump blood to your lungs to get rid of the carbon dioxide and pick up oxygen. And we call this the pulmonary circuit. The left side of the heart then receives that oxygenated blood from your lungs and pumps the blood to the body tissues, and we call that the systemic circuit. Here are the chambers of the heart that I'm going to let you guys review on your own, the atria and the ventricles and what they all do. And then this shows you the systemic and pulmonary circuits of the heart and how they're connected. So remember, the right atria and right ventricle are oxygen poor blood because they're receiving the oxygen poor blood from the body's tissues. They'll pump that oxygen poor blood to your lungs where it'll get rid of the carbon dioxide. And then your lungs will pick up oxygen, put the oxygen into the blood, and that oxygen-rich blood returns to the left side of the heart in the atrium and ventricles. And then the left side of the heart pumps out the oxygen-rich blood to all of your body's tissues that need oxygen to create energy, ATP, and then that travels through the systemic circuit. The systemic circuit involves blood going to and from your body's tissues from the heart, and the pulmonary circuit involves blood going to and from the lungs from the heart. A little bit more about the anatomy of the heart. It's about the size of a fist. It's located in the mediastinum, anterior to your vertebral column and posterior to your sternum. So here's a look at where the heart is located within the mediastinum, within the rib cage. Here's a transverse section showing how the heart is anterior to your vertebra, but posterior to the sternum or the breastbone. The base of the heart leans toward the right shoulder, so your heart is kind of turned so that the anterior angle, the right atria and right ventricle kind of make up the anterior angle, and then it kind of sits back on itself on the base. The apex points towards your left hip, and the apical impulse, it can be palpated between your fifth and sixth ribs just below the left nipple. So here again is the location of the heart in the mediastinum. There's your apex. You can see here the majority of the anterior of the heart is made up of the right atria and right ventricle. The left atria kind of makes up the base of the heart, so it sits kind of back. The pericardium is the double-walled sac that surrounds the heart. It's made up of two layers, the fibrous pericardium, which functions to protect, anchor heart to the surrounding structures and prevent overfilling. And then the deep two-layered serous pericardium is made up of the parietal layer, which lines the internal surface of your fibrous pericardium, and the visceral layer on the external surface. And the two layers are separated by a fluid-filled pericardial cavity to decrease friction. So this shows you the layers of the heart, the fibrous pericardium, which connects the heart to the surrounding tissue. The myocardium is made up of the cardiac muscle cells, the epicardium, and then the endocardium surrounding the chamber of the heart. Pericarditis, so and again, anytime we see the word itis, that means inflammation. So a pericarditis is an inflammation of the pericardium. It roughens the membrane surfaces, causing a pericardial friction rub or a creaking sound, which can be heard with a stethoscope. Cardiac tamponade is when excess fluid leaks into the pericardial space. This can compress the heart's pumping ability, and treatment is actually to draw excess fluid out, usually with a syringe. Here are the three layers of the heart wall. The epicardium is the visceral layer. The myocardium will be the cardiac muscle cells. And the cardiac skeleton is what we describe the crisscrossing, interlacing layer of connective tissue to help anchor the cardiac muscle fibers. It supports your great vessels, which are your pulmonary artery and your aortic artery, and all the valves to help limit the spread of action potentials to specific paths so that everything contracts as a unit in the cardiac muscle cells. So here's a look at the circular and spiral arrangement of the cardiac muscle bundles. in the myocardium of the heart. And again, it helps the heart to contract as a unit, and it really helps to then squeeze the chambers very efficiently to pump blood out. The endocardium is the innermost layer. It's continuous with endothelium lining of blood vessels. It lines the heart chambers and covers the cardiac skeleton of valves. So here's a look at that endocardium layer. We're looking at this innermost layer right there. The internal features of the heart, I'm going to let you guys review a little bit of this on your own. You will need to be responsible for this, but a lot of it is review from anatomy. So especially a picture like this, you should be very familiar with the names of the different types of valves, the interventricular septum. You should know the order of blood supply through the heart. So it goes from the right atrium through the tricuspid valve into the right ventricle, through the pulmonary valve to the pulmonary trunk and arteries, comes back into the heart via the pulmonary veins into the left atrium, through the bicuspid valve into the left ventricle, and then out again through the aorta. So you should be very familiar with the anatomy of the heart and the direction of blood flow through the heart too. There's some surface features of the heart. The coronary sulcus is the groove that encircles the junction of the atria and ventricles. We have another sulcus on the anterior side of the interventricular septum, and then a posterior interventricular sulcus, which is a landmark on the posterior inferior surface. So here are some surface anatomical structures of the heart on the front and the back. So this again takes us through some more anatomy. So I'm going to go through these a little quicker, but you should review the atria, where they're located, what the auricles are, the different muscles, which are the ridges inside the atria, what veins empty into the right and left atria. And then the ventricles, they are the inferior chambers of the heart. The papillary muscles will anchor the chordae tendineae, which are the little strings that attach to your heart valves. The trabeculae carneae are the irregular ridges on the muscle on the ventricular walls themselves. The ventricles themselves and where they lead to, so where blood goes after they're into the ventricles. And this is a look at a cadaver heart, which is again always fun to see. Your hearts don't look like this in real life. They look more like this, a cadaver heart with just kind of a beige colored or natural colored tissue. And this is a really cool picture because you can see the atria, the ventricles, the trabeculae carneae, the valve, the tricuspid valve connected to the chordae tendineae, to the papillary muscle, and then the pulmonary trunk, leaving the right ventricle, and the aorta leaving the left ventricle. And then the three outpocketings from the aorta, which is a great picture. This is a great animation. So download the PowerPoint from Canvas to take a look at that animation. Another gross anatomy, a cadaver heart. Some of the surface structures, you can see the anterior interventricular artery. So again, these major arteries, the right coronary artery, these supply blood to the heart itself because your blood your heart needs oxygen to contract and move as well. So in heart attacks, one of these arteries will get blocked, usually due to atherosclerosis or a buildup of plaque. And when that happens, it can damage the tissue around the heart because it's not getting oxygen, and that's what causes a myocardial infarction or a heart attack. So your heart valves ensure a unidirectional blood flow through the heart. They open and close in response to pressure changes. Here are your two major types of valves, where they're located. So you have 4 altogether, 2 atrioventricular and 2 semilunar. So be sure you know those very well. No valves are found between the major veins and atria. This isn't a problem because the inertia of incoming blood prevents any backflow, and heart contractions compress venous openings. So here's a look at the valves and where they're located if we would take a cross section of the heart. Here then are the valves, a great review from anatomy. This is a really cool picture of a live view showing a papillary muscle connected to the chordae tendineae, which will be attached to the cusps or the flaps of the tricuspid valve. So a really cool view of the inside of the heart there. Here's the function of the atrioventricular valves. So blood will return to the heart and that fills up the atria. This presses against your AV valves and this increased pressure forces your AV valves open. So blood will flow kind of naturally into the ventricles from the atria. And as the ventricles fill, the AV valve flaps will hang limply into the ventricles. And then when the atria contract, which will be one of the phases in the cardiac cycle, this contraction will force additional blood into the ventricles. The ventricles will then contract, forcing the blood against the AV valve cusps. And that kind of force, the ventricles contracting and the increase in pressure within the ventricles will force your AV valves to close. And when your AV valves slam shut, the doctors are able to hear that sound in a stethoscope. So that's the first heart sound we say when they hear the blub dub, blub dub, blub dub in the stethoscope. That first closing of the AV valves is the kind of forcing closing that they hear. The papillary muscles contract and the chordae tendineae tighten, and they will prevent the valves from everting back into the atria. Everting means the valves will not kind of move into the atria at all. They'll just stay shut kind of right here as they should with the ventricle below and the atria above. Again, here's a look at the heart valves when they are closed, and you can see the tricuspid has 3 cusps to it, and the bicuspid valve on the left side of the heart has 2 cusps to it. Here are the semilunar valves, which prevent backflow from the major arteries, the pulmonary trunk and the aorta, back into the ventricles. So review where they are located. As ventricles contract and the intraventricular pressure rises, blood will be pushed up against the semilunar valves, forcing them to open. So when blood gets ejected from your ventricles, whether it's going into the pulmonary trunk or the aorta, the increase in pressure and the contraction of the ventricles then forces blood through the semilunar valves and forces them to open. As the ventricles relax and the intraventricular pressure falls, the blood flows back from the arteries, filling the cusps shown here, and it forces them to close so that we don't get any backflow back into the ventricles. There's 2 conditions that severely weaken the heart. An incompetent valve is when blood backflows, so the heart repumps the same blood over and over. And valvular stenosis, which when you have a stiff flap that constricts the opening, when the heart needs to exert more force to pump the blood. A defective valve can be replaced with a mechanical, an animal, or a cadaver valve, which is really helpful. So here's the pathway of blood through the heart that you should know and you should study. So I'll let you guys review this on your own. Here's the blood flow through the heart, kind of a picture representation, which is really helpful. So please review this, know where blood flows to the heart. Then it eventually gets to the lungs to pick up oxygen, and then the oxygen-rich blood returns back to the heart in this schematic picture. And again, if you can kind of remember that the heart is a double pump, each side supplying its own circuit. So again, the right side of the heart supplies blood to the pulmonary circuit, and the left side of the heart supplies blood to the systemic circuit. Equal volumes of blood are always pumped to the pulmonary and systemic circuits. The pulmonary circuit is a short, low pressure circulation, and the systemic circuit is a long, high friction circulation. And the anatomy of the ventricles will reflect these differences. So the left ventricle walls are about 3 times thicker than the right ventricle. So the left ventricle is the one that will pump with much greater pressure because it's supplying blood to all of the body's tissues. So here's a look at the anatomical differences between the right and the left ventricles. The coronary circulation then is the blood supply to the heart muscle itself. It's the shortest circulation in the body because it just has to go from the heart and then arteries to the heart itself. It's delivered when the heart is relaxed, and the left ventricle receives most of the coronary blood supply because it's doing most of the pumping, most of the work. Here are your coronary arteries. They have a left and a right coronary arteries. They arise from the base of the aorta. They encircle the heart in the coronary sulcus. The arteries contain many anastomoses, which are just junctions that provide additional routes for blood supply. but they cannot compensate for a coronary artery occlusion or a blockage. If there is a blockage within a coronary artery, usually a stent needs to be put in to alleviate that blockage, or a surgery bypass occurs where they take an artery and try to bypass the blockage. Here's the left and right coronary artery and their branches and what they supply, and then just a picture and anatomical review of where they're located. Coronary veins will just collect blood from the capillary beds, empty into the coronary sinus, empty into the right atria. So these are the major veins that just drain the blood from the heart. So here's a little bit more of the coronary anatomy. Some homeostatic imbalances, and angina pectoris is thoracic pain caused by fleeting deficiency in blood delivery to the myocardium, where the cells are weakened. And a myocardial infarction is a heart attack with prolonged coronary blockage. Some areas of cell death can be repaired with non-contractile scar tissue, but usually there's some sort of intervention needs to take place as soon as possible. Cardiac muscle fiber then, so a little bit of review about cardiac muscle from its anatomy. Cardiac muscle cells are striated, short, branched, fat, interconnected with intercalated discs, which are connecting junctions between cardiac cells that contain desmosomes and junctions, which allow ions to pass from cell to cell to allow for the heart to be very functionally succinct, which means they will contract as a single coordinated unit. There's intercellular space, which contains capillaries. It connects cardiac muscle to the cardiac skeleton, which gives cells something to pull against. And here's a look at cardiac muscle cells underneath the microscope. You can see the gap junctions, the desmosomes, the cardiac muscle cells, the nucleus, and then the intercalated discs. And you can see that how the cardiac muscle fibers will branch. A couple similarities between skeletal and cardiac muscle and differences. Muscle contraction will always be preceded by a depolarizing action potential. This depolarization wave will travel down T tubules, which will release calcium. And then we get an excitation contraction coupling where the calcium binds troponin, causing the filaments to slide. So that's a similarity with skeletal muscle. Some differences are that some cardiac muscle cells are self-excitable, meaning some are contractible, which they're responsible for the contracting of the heart. And some cardiac muscle cells are what we call pacemaker cells, where they're non-contractile cells that will spontaneously depolarize. They initiate the depolarization of the entire heart. They do not need nervous system stimulation. So your heart can stimulate or start its own heartbeat. Heart contracts as a unit, so all the cardiomyocytes contract together or none at all. The contraction of all cardiac myocytes ensures effective pumping action. The skeletal muscles in response will contract independently. An influx of calcium from extracellular fluid triggers calcium release from the sarcoplasmic reticulum in the cardiac cells. This depolarization opens slow calcium channels. Skeletal muscles do not use any extracellular calcium in comparison. Tetanic contractions cannot occur in cardiac muscles. So your cardiac muscle fibers have longer absolute refractory periods. So in this absolute refractory period is almost as long as the contraction itself. This prevents a tetanic contraction and allows the heart to relax and fill as needed to be an effective pump. The heart relies exclusively almost on aerobic respiration. That means it must need oxygen. So your cardiac muscle has lots of mitochondria. It has a greater dependence on oxygen. So your heart cells cannot function without oxygen. Skeletal muscles, in comparison, can go through what we call fermentation when oxygen isn't present. And both types of tissues can use other fuel sources. Cardiac is much more adaptable to other fuels, including lactic acid, but again, your cardiac muscle tissue needs oxygen. And here is a good kind of review chart for the differences and similarities between skeletal and cardiac muscle. So that will go to part B of this lecture. And we'll make sure you guys are looking at it here. So part B of chapter 17 takes a look at some of the electrical events of the heart. So your heart depolarizes and contracts without any nervous system stimulation, although its rhythm can be altered by your autonomic nervous system. So your nervous system, remember, can speed up heart beats or slow down. The coordinated heartbeat is a function of the presence of gap junctions and the intrinsic cardiac conductive system, which is a network of non-contractile autorhythmic cells that initiate and distribute an impulse to coordinate the depolarization and contraction of the heart. The action potential is initiated by pacemaker cells, and your cardiac pacemaker cells have an unstable resting membrane potential called a pacemaker potential. And there's three parts of the action potential. The pacemaker potential is when the potassium channels are closed, slow sodium channels are open, causing the interior to become more positive. And then we get a depolarization and a repolarization phase, which initiates the action potential of these pacemaker cells. And this just shows kind of the pacemaker potential, the depolarization and the repolarization phase of these action potential stimuli of the typical cardiac pacemaker cells. The sequence of excitation, so the cardiac pacemaker cells pass impulses in the following order across the heart in about 0.2 seconds. And you should know this order. They start in the sinoatrial node, and we'll talk about where that is located in the heart. Then the electrical impulses travel to the atrioventricular node, to the atrioventricular bundle, to the right and left bundle branches, and then to the Purkinje fibers. And again, this is just the sequence of excitation of these cardiac muscle cells. So the intrinsic conducting system, what sets this basic rhythm in motion, again, without nervous system stimulation. So again, the heart initiates its own heartbeat. The sinoatrial node starts. So the sinoatrial node is considered the pacemaker of the heart. It's located in the right atrial wall. It will depolarize faster than the rest of the myocardium, and it generates an impulse, which we call the sinus rhythm. The impulse will then spread across the atria to the AV node. The AV node is then in the inferior interatrial septum, so kind of in the wall between atria at the base of it. In the AV node, this causes a delay of the impulse of about 0.1 second because the fibers are smaller in diameter, have fewer gap junctions. This delay allows the atrial to contract to make sure all the blood flows from the atria to the ventricles before the ventricles contract. The atrioventricular bundle, also called the bundle of His, is located in the superior interventricular septum. So between the ventricles, we have the interventricular septum, and in the superior, this is where the bundle of His is located. This is the only electrical connection between atria and ventricles. So the atria and ventricles are not connected via gap junctions. They're only connected via this bundle. The right and left bundle branches then are the two pathways within the interventricular septum that both carry impulses toward the apex of the heart. And then we get to the subendocardial network, which we also know as the Purkinje fibers. This is just the complete pathway through the interventricular septum into the apex and all the ventricular walls. It's more elaborate on the left side of the heart. So the AV bundle and subendocardial conducting network will depolarize to carry the impulse to all of the muscle cells of the heart within the heart walls. And again, the process from initiation at the SA node to complete contraction takes about 0.2 seconds. And again, remember, this is important. So this shows the exact kind of, again, way that the impulses travel through the heart. And remember that these are the electrical impulses that will cause the atria and ventricles to contract. So we need the electrical impulse to cause contraction of both chambers. So you should know the order of these electrical impulses. Defects in the intrinsic conduction system may cause an arrhythmia, which is an irregular heart rhythm, where there's an uncoordinated atrial and ventricular contraction. So there's some sort of defect in this electrical conduction system, or a fibrillation, which is a rapid irregular contraction. The heart will become useless for pumping blood because there's no rhythm to it. The atria and ventricles are just contracting however they want. This will cause circulation to all the body cells to cease, and could result in brain death. Treatment is a defibrillation event, which is where they I'm sure you've seen this, they shock the person with the paddles to try to interrupt the chaotic twitching and give the heart a clean slate to start regular normal depolarizations again. A defective SA node may cause an ectopic focus, which is an abnormal pacemaker that takes over pacing. If the AV node takes over, it sets a junctional rhythm a little bit slower. Extrasystole is a premature contraction that could cause delay in the next impulse. So these are all kind of homeostatic imbalances of the heart. To reach the ventricles, an impulse must always pass through the AV node. So if the AV node is defective, we call that a heart block, where few impulses, a partial block, or no impulses, a total block, are reaching the ventricles. So the ventricles will beat at their own intrinsic rate. They're too slow to maintain adequate circulation, and the treatment is to put in an artificial pacemaker, which is a little metal lead or wire which bypasses this block to recouple the atria and ventricles together. The heartbeat is modified by the autonomic nervous system, as we remember, via cardiac centers in the brain, the medulla oblongata. The cardioacceleratory center sends signals through the sympathetic trunk to increase both heart rate and force, and the cardioinhibitory center is via parasympathetic signaling, and that is via the vagus nerve to decrease the heart rate. So this is just to look at autonomic innervation of the heart, whether it's by the vagus nerve, the parasympathetic innervation will decrease the heart rate, or sympathetic innervation by the cardiac nerve will increase heart rate and the force of contraction. An electrocardiograph then can detect electrical currents generated by the heart. An electrocardiogram and ECG is a graphic recording of electrical activity. It's a composite of all action potentials at a given time, not a tracing of a single action potential. Electrodes are placed at various points on the body to measure a voltage difference, and the 12-lead ECG is the most typical. The main features of an electrocardiogram is the P wave, and you should know all of this, which is the depolarization of the SA node in atria, so where the electrical signal is starting. The QRS complex is the ventricle depolarization, and the T wave is the ventricular repolarization. And then we have intervals, which are spaces between kind of the peaks. The PR interval is the beginning of atrial excitation to the beginning of ventricular excitation. The ST segment signifies when the entire ventricular myocardium is depolarized. And the QT interval is the beginning of ventricular depolarization through ventricular repolarization. And this is a showing of how several electrodes are placed on this patient's skin to record an ECG, because the skin cells can record the electrical activity of the heart. A round antenna is placed near the patient's left shoulder to read his pacemaker data, because this patient has a pacemaker implanted. So this is a normal ECG. The P wave again stands for atrial depolarization. The QRS complex stands for ventricular depolarization, and then the T wave stands for ventricular repolarization. And any sort of if anything is wrong within these data graphs, they will show an abnormality, and we'll get to some of those abnormalities and what they look like. So this is a really good kind of tracing. It takes you through what happens and what happens through each node and how the electrical impulses are spread, and then that depolarization, repolarization, how it gets kind of seen on the ECG wave. Changes in patterns or timings of the ECG may reveal diseased or damaged heart or problems with the heart's conduction system. Problems that can be detected. An enlarged R wave may indicate an enlarged ventricle. An elevated or depressed ST segment usually indicates a cardiac ischemia or a heart attack. Problems that can also be detected, a prolonged QT interval can reveal a repolarization abnormality that could increase the risk of ventricular arrhythmia. So here's a look at normal sinus rhythm, a normal ECG trace. So everything looks normal. All the PQRST complexes, they're all accurately spaced. Here's a look at a junctional rhythm. So the SA node is non-functional, and as a result, the P waves are absent and the AV node paces the heart a little bit slower at 40 to 60 beats per minute. Here's a look at a second-degree heart block. So the AV node is failing to conduct some SA node impulses. So as a result, there are more P waves than QRS complexes because the atria are contracting, but sometimes you just see this line here, the ventricles aren't contracting. So in this tracing, there will be usually 2 P waves for each QRS complex, and that's why we call this second-degree heart block. It's a 2-to-1 ratio of P waves to QRS complexes. Here's a look at ventricular fibrillation, where the electrical activity is totally disorganized. Action potentials occur randomly throughout the ventricles. This results in chaotic, grossly abnormal ECG deflections. It can be seen in acute heart attack and also after electrical shock. So these 3 you should know. There might be a test question about those and what they look like. The mechanical events of the heart, systole refers to the period of heart contraction. Diastole refers to the period of heart relaxation. And the cardiac cycle is all the blood flow through the heart during one complete heartbeat. Atrial systole and diastole are followed by ventricular systole and diastole. The cycle represents series of pressure and blood volume changes, and the mechanical events follow the electrical events seen on the ECG. There's 3 phases of the cardiac cycle following the left side, starting with total relaxation. And these cardiac cycles, what the workshop was about this week. If you guys went to a workshop, I hope you guys did, but the cardiac cycle workshop is really helpful. Try to get to that one. Remember, you have to get to 3. So here are the mechanical events of the heart. Ventricular filling occurs from mid to late diastole, where the pressure is low. 80% of blood flows passively from the atria through open OV valves into the ventricles from the atria, and the semilunar valves are closed. Atrial depolarization triggers atrial systole, which is the P wave, causing the atria to contract, pushing the remaining 20% blood into the ventricle. And end diastolic volume refers to the volume of blood in each ventricle at the end of ventricular diastole. Depolarization spreads to the ventricles. This is called the QRS comp wave, and the atria will finish contracting and return to diastole while ventricles begin systole again. Isovolumetric contraction, we have some isovolumetric phases, and that just means that no change in volume is occurring in the ventricles because iso means same. So the atria will relax, the ventricles begin to contract, and the rising ventricular pressure causes the closing of your AV valves. The isovolumetric contraction phase is a split-second period when the ventricles are completely closed. All the valves are closed, the volume remains constant, and the ventricles continue to contract. And when the ventricular pressure exceeds pressure in the large arteries, your semilunar valves are forced open, and the pressure in the aorta reaches about 120 millimeters mercury, which is the top blood pressure in a normal person. That we'll talk about eventually, next chapter. Isovolumetric relaxation phase. This follows ventricular repolarization. The end systolic volume is the volume of blood remaining in each ventricle after systole. Ventricular pressure drops, causing backflow of blood from the aorta and pulmonary trunk that triggers closing of semilunar valves. The ventricles are completely closed chambers momentarily, and this is referred to an isovolumetric relaxation phase. The closure of aortic valves raises the aortic pressure as backflow rebounds, and this is referred to the dicrotic notch. The atria continue to fill during ventricular systole, and when atrial pressure exceeds ventricular pressure, AV valves will open and the cycle begins again. A normal heartbeat is about 25 times per minute, and the cardiac cycle lasts about 0.8 seconds. And we are able to measure all these events to make sure the heart is in accurate rhythm. So here's a look at the cardiac cycle showing differences in pressure and volume and showing the different heart sounds. And the heart sounds again refer to when the AV valves closed to when the semilunar valves closed. And this ties in all the cardiac cycle, all the events found in a heartbeat, and you can see the flow of blood, and it takes you through where each event kind of tracks on the same graph. Heart sounds are the lub-dub sounds associated with closing of the heart valves. The first sound is the closing of the AV valves, and the second sound is the closing of the SL valves. There's a pause between lub-dubs, which indicate heart relaxation. Your mitral valves close slightly before the tricuspid, and the aortic closes slightly before the pulmonary valve, and the differences allow for auscultation of each valve, or the hearing, when the stethoscope is placed in the 4 different regions. So these are the 4 different regions where the doctor will listen. So you remember the doctor listens to your chest and usually moves the stethoscope around. He's listening to the closing of all the specific valves. A heart murmur is an abnormal heart sound heard when the blood hits any sort of obstruction. It usually indicates a valve problem, whether that's an incompetent or an insufficient valve, failure to closing completely, allowing backflow, or a stenotic valve where the valve fails to open completely, restricting blood flow. Cardiac output then is the amount of blood pumped out by each ventricle in 1 minute. It's equal to the heart rate times the stroke volume. And the stroke volume is the volume of blood pumped out by 1 ventricle in each beat. This correlates with the force of contraction, and normal cardiac output is equal to the normal heart rate times the stroke volume, first to about 5¼ liters per minute. I want you to know the equation what cardiac output equals, which is just, again, heart rate times stroke volume. Outside of that, you don't need to know anything else. This will take you through a couple more regulation of cardiac output. Cardiac output will be affected by factors that regulate stroke volume and regulate heart rates. And these are different factors involved in determining cardiac output. And again, it's factors that are involved in regulating stroke volume and regulating heart rates. So these are just different factors that will regulate how much blood or cardiac output your heart is outpacking. More of these kind of mathematical equations you guys don't need to know. Again, the big one is I just want you to know what cardiac output is equal to heart rate times stroke volume. Preload, contractility, and afterload have to do with the degree of stretch of the heart muscle, which will also affect stroke volume. Contractility will affect stroke volume. Norepinephrine increases heart contractility, so norepinephrine will speed up the heart rate or cardiac output. Afterload is the back pressure exerted by arterial blood, so it's the pressure that the ventricles must overcome to eject blood. So these are all regulators of stroke volume, which will in turn regulate cardiac output. Chemical regulation of heart rate can be due to hormones and ions. Epinephrine will increase heart rate and contractility. Ion concentration levels must be maintained for normal heart function. And if we have an imbalance of ion levels, that can be very dangerous to the heart as well. Hypocalcemia depresses the heart. Hypercalcemia increases heart rate. Hyperkalemia alters the electrical activity, which could lead to a heart block and cardiac arrest. And hypokalemia can result in a feeble heartbeat or an arrhythmia. Other factors that can influence your heart rate are your age. Fetuses have faster heart rates, and that declines with age. Gender, females normally have a faster heart rate. Exercise increases heart rate, but trained athletes can have a slower heart rate. Body temperature, the heart rate increases with body temperature. Tachycardia is an abnormally fast heart rate, anything above 100. And if it's persistent, it may lead to fibrillation. Bradycardia is a slow heart rate, less than 60 beats per minute. It could result in inadequate blood circulation in non-athletes, but again, bradycardia may be a desirable result of endurance training because athletes have the ability for their heart to function at a much greater capacity without working as hard. Congestive heart failure is a progressive deficiency where cardiac output is so low that the blood circulation is inadequate to meet tissue's needs. It usually reflects a weakened myocardium caused by coronary atherosclerosis, which is a clogged artery caused by fat buildup. It will impair oxygen delivery to cardiac cells, and the heart can become hypoxic, where it contracts inefficiently. Persistent high blood pressure is really scary because this is aortic pressure causing the myocardium to exert more force. Chronic increased end systolic volume causes the myocardium to hypertrophy or get larger, causes it to become weaker. Multiple myocardial infarcts where the heart becomes weak as contractile cells are replaced with scar tissue. And dilated cardiomyopathy is when the ventriculus stretch and become flabby and the myocardium deteriorates. The congestive heart failure is when either side of the heart can be affected. The left side failure results in pulmonary congestion. The blood backs up in the lungs. The right-sided failure results in peripheral congestion where blood pools in body organs causing edema. And failure of either side ultimately weakens the heart, which leads to decompensated or a seriously weakened heart. The treatment can be a removal of fluids or drugs to reduce the afterload and increase contractility. That's the end of this chapter. Thanks for listening, guys.